Hello everyone, welcome to Nuts Bestie Explains. Today we continue this video with 10 more important OBGM midwifery nursing practical exam Viva questions. First one is Leopold's maneuver. Okay, in fundal examination or part of antenatal assessment, when a patient with obstetric client comes to us, assessment of fetal lie, presentation and positions is very important. So as part of antenatal assessment, these Leopold's maneuvers are done. Let's see what are those Leopold's maneuvers. Introduction. Leopold's maneuver are systematic abdominal palpation techniques used to determine fetal lie. So by following these maneuver, what we can identify fetal lie and presentation, okay, which is the presenting part, position of the patient, baby fetus, that is fetal lie, then fetal position, in which position the fetus is situated, and engagement of the presenting part. This is performed after 28 weeks of gestation. Please remember this. Leopold's maneuver is performed after 28 weeks of gestation. Let's see, then preparation. To perform these Leopold's maneuvers, the preparation what is required is explain procedure to the mother. Why we are performing this Leopold's maneuver? To identify the lie, position, presentation and engagement in the presenting part. Okay. Ask mother to empty the bladder before any antenatal or abdominal palpation examination. You should ask the mother to empty the bladder. Position women in dorsal recumbent position, you can see in the picture. Flex knees to relax. You can ask the mother to flex the knees so that she will be relaxed. Her abdominal muscles will be relaxed. Stand on the right side of the woman. Okay, then hands should be warm. So before touching the mother's abdomen, you should rub your hands, then touch the mother's abdomen. Provide privacy and comfort, very important aspect. Start with the first maneuver, that is fundal grip. We call first maneuver as fundal grip. So fundal part palpation you have to start. The purpose is to identify fetal pole in the fundus, which is the part present in the fundal region. To identify that, we should start with fundal grip. Method. Examiner faces the mother. As we say, examiner has to stand the right side and face towards the mother. Okay, face towards the mother's head. And by placing two hands, we should both hands palpate uterine fundus. Fundus part of the uterus, you have to start palpating how it is shown in the picture. Okay, fundal grip. Findings. What you can identify, you have to in round motions, okay, movement, circular movements. If you palpate, you will feel the fetal parts, round, hard, movable mass. If you feel round, hard, movable mass, that means fetal head is on the fundal region, okay. Or broad, soft, irregular mass, okay, broad, soft. If you feel softness, irregular mass, that indicates buttocks presented. If you see the picture, there are buttocks limbs, okay, back. So soft, broad, irregular mass, if you feel, that indicates buttocks is present at the fundal region. This fundal grip helps determine longitudinal lie. Okay, longitudinal lie. So if you feel buttocks here, definitely head will be on the lower side near symphysis pubis. So this indicates a cephalic presentation, or in case of breech presentation, buttocks will be on the downside, and fundal region you will identify hard mass, that is nothing but head of the fetus. Then second maneuver. First maneuver is fundal grip. Second maneuver is lateral grip. Okay, lateral side. Once you finish the fundal palpation, go to the lateral palpation. Okay, or umbilical grip. Method. Both hands placed on either side of the uterus. Gentle pressure on alternatively both sides. Gentle pressure you should apply to feel the parts of the fetus. Findings. If smooth, curved, firm surface, okay, if their arrow mark is shown, smooth, curved, firm surface indicates back of the fetus, fetal back. Irregular small parts, okay, irregular small parts, if you feel, those are the limbs, fetal limbs. This lateral grip maneuver or umbilical grip maneuver helps to determine position of the fetal back. Okay. Then third maneuver is Pollick's grip. Fundal grip, lateral grip. Third one is Pollick's grip. Pelvic grip or first pelvic grip we call this maneuver. This is method. Examiner faces the mother. Thumb and fingers grasp. Her thumb and fingers grasp the part. Okay, grasp the lower abdomen just above the symphysis pubis. If after holding like that, if the part is movable, if that part is moving, presenting part, that means still the presenting part of the fetus is not engaged into the mother's pelvis. Okay, mother's pelvis. And if that part is fixed part, that means if it is not moving, that means it is engaged into the pelvis of the mother. This Pollick's maneuver grip, okay, Pollick's grip helps determine engagement of the presenting part. Okay, Pollick's grip will tell us the engagement of the presenting part, whichever is presenting part, fetal head or buttocks, whether it is engaged or not. This we will identify with Pollick's grip. Fourth maneuver is second pelvic grip or method of descent. For this, examiner faces woman's feet. Towards woman's feet, the examiner has to turn by placing both hands on either side of the lower abdomen. As shown in the picture, you have to do like this. Hard round mass that indicates head is a presenting part, so cephalic presentation. Broad soft mass that means breech presentation, that indicates buttocks as a presenting part. This second pelvic grip maneuver helps determine degree of head descent, attitude of fetal head. Okay, the degree of how much the head is descent and attitude of fetal head. So these are the Leopold's maneuver, what it is, and preparation. We have seen fundal grip, lateral grip, Pollick grip, and the second pelvic grip. You may just get a question as a Pollick's grip for 2 marks also. Please remember, it is one of the Leopold's maneuver. Third maneuver also called as pelvic grip or first pelvic grip. Method findings, it helps to determine the engagement of the presenting part. Okay, this you can draw a brief picture or write about the maneuver. Okay, like this you will get the question. So this is about Leopold's maneuver for the assessment of fetal life presentation and position. Same thing you can see here, fundal grip, lateral, second Leopold, Pollick's grip and pelvic grip. Okay, same. Assess the presenting part. Next question which you may be asked is stages of labor. How many stages of labor which we already know? There are 4 stages of labor. Let's see each stage in brief. First stage is early labor or latent phase, active phase and early labor phase. So early labor or latent phase, hours to days, contractions very mild and irregular, cervix effacing up to 4 centimeters, it will dilate. Monitor contractions, support and hydrate. Keep mother hydrated. Active phase or active labor or phase. This 4 to 8 hours duration, contractions strong and regularly. Mother will be getting contractions. 4 to 7 centimeters cervical dilatation can be observed. Care assist fetal heart rate. Manage pain of the mother. Assist with breathing. Okay, you can assist the mother with breathing by deep breathing exercises. Early labor or latent phase, duration hours to days, mild irregular, cervix up to 4 centimeter dilated. So first stage of labor. Then second stage, if you see, delivery of the baby. Duration 20 minutes to 2 hours it may take. Sometimes prolonged labor, it may be go up to 2 hours also. If the pelvic shape is not proper, paracoid pelvis is not there, other pelvis, android pelvis. Okay. Then contractions continue to be strong. Contractions will be strong at the second stage of labor. Cervix fully dilated, 10 centimeters dilated cervix you can observe. Baby descends through the birth canal. Care assist with pushing. Help the mother. Ask her to push. Monitor fetal heart rate. Support the mother. Prepare for newborn care. All the articles required for newborn care that has to be kept ready. Third stage of labor, the delivery of placenta. Here baby is delivered. Then third step is placenta has to be expelled out. Duration 5 to 30 minutes after the baby is delivered. Contractions will be mild, help expel the placenta. Placenta delivered after the baby. Care, ensure complete placenta delivery. Make sure placenta with membranes, umbilical cord completely delivered. It should not be any parts left over in the uterus. Very careful. Monitor for bleeding. Provide immediate post-delivery care to the mother. Then fourth stage of labor, recovery phase. In this duration is 5 to 30 minutes post-baby. Contractions mild, help expel the placenta. Placenta delivered after baby, ensure complete placenta delivery and monitor for bleeding. These are the 4 stages of labor. Okay. So if you get a question, how many stages are there in labor? 4 stages you have to tell. First stage, second stage, third stage, what happens? Delivery of placenta. Second stage, delivery of baby. Fourth stage, recovery phase. Okay. Then next question is mechanism of labor. Very important. Even in final year also you may be asked to demonstrate with pelvis and the fetal baby. You may be asked to demonstrate the mechanism of labor. So first step is head floating before engagement. Head is not engaged. Then engagement of the head. Then flexion. Okay, head has to flexion and descent. Both happens at same time. The head is flexed towards the body and a descent. Okay, like it moves downwards. Third step, further descent and internal rotation. Internally, the head will rotate. You can observe the pictures here. Okay, internal rotation. Then fourth step, complete rotation and beginning of extension. Okay, before engagement, head floating. Then flexion and descent and internal rotation, complete rotation and beginning of extension. Then complete extension. Once beginning of extension, then head will completely extend and head comes out. Okay, you can see crowning. Okay, the head part you can observe from the mother's vaginal opening. Okay, complete extension, restitution. Okay, that is external rotation. Once the head flexes and comes out, the head rotates. Okay, external rotation of the head. Then delivery of anterior shoulder. Okay, so one shoulder is delivered, anterior shoulder. Then delivery of the posterior shoulder. Once the shoulders are delivered, immediately the person is performing the labor will hold the baby's head body and they will deliver the rest of the body. These are the steps of mechanism of labor. Head floating before engagement, flexion, descent, further descent, internal rotation, then complete rotation and beginning of extension, complete extension, restitution. Okay, restitution is externally head will be rotated to one side, then delivery of anterior shoulder, then delivery of posterior shoulder. These are the steps in mechanism of labor. Next one is lower segment cesarean section. What are the indications? You may get this for theory 2 marks question also, or you may be asked for indications of LSCS in practical exam. Small pelvis. If the pelvis is small and the baby cannot pass through the pelvic opening, then LSCS is indicated. Contractive pelvis, CPD. Okay. Then oligohydramnios. Okay. Less amount of amniotic fluid plus fetal Doppler changes. Then placenta previa, breech presentation, macrosomia, baby is very big, reactive CTG variation, baby lie in transverse line. Okay, baby position is transverse. Okay, instead of longitudinal, baby position is transverse. Okay, normal is longitudinal. Here baby lie is transverse. That case rotation can be done, external rotation. If it is not possible, LSCS is advised. Emergency such as cord prolapse. These are the indications of lower segment cesarean section. Next question is types of incision. In LSCS, there are different types of incisions you can see here. First one is low transverse incision. Like this, low transverse incision is given. Low vertical incision. Low vertical incision is given. Classical incision. Okay, classical incision. Okay, commonly for any general abdominal surgeries they do this classical incision. Another one is J incision. Okay, in the shape of J, incision is given. So low transverse, low vertical, classical incision and J incision. These are the types of incision. Next, what are the equipment required for conduction of a vaginal delivery? Okay, for this, retractor, Stone's retractor, forceps, okay, blades, scissors, forceps, cloth, kidney trays to collect the placenta after expulsion. And along with this, in the OT, other equipment like suction apparatus is also kept ready. Suture material has to be kept ready. Okay. Then for cutting the cord clamps, blade also you have to keep ready. And for holding the baby, some sponges you have to keep ready for holding the baby, covering the baby and all. You have to keep the towel, everything ready. Next question is placenta. Okay. So I explain about placenta like that. You may be asked an open-ended question. So the placenta is a vital temporary organ that develops in the uterus during pregnancy to support fetal development. So it is a very important vital temporary organ. Once the baby is delivered, placenta also will be delivered. Its purpose also will be over. Temporary organ that develops in the uterus during pregnancy to support the fetal development. This placenta supports the fetal development. It acts as a lifeline, facilitating oxygen supply, nutrients and waste exchange between mother and baby takes place. Very important functions: oxygen supply, nutrient supply and waste exchange between mother and baby, while also producing essential hormones. It also produces hormones and providing immune protection, and it is expelled after birth. You can observe the structure of the placenta and umbilical cord. Next question is umbilical cord. You may be asked questions about umbilical cord. Umbilical cord is a flexible 50 to 60 centimeter long tube-like structure serving as a lifeline. It serves as a lifeline between mother and the fetus. Okay, lifeline, connection between the placenta and the fetal body, which transports oxygen, nutrients through one vein and removing waste through two arteries. See, it is clearly given here. There will be one vein. You can observe here umbilical vein, and the wastage is removed through two umbilical arteries. Okay, two umbilical arteries you can see in the picture. Two umbilical arteries and one umbilical vein. This question also you may be asked, how many veins arteries present in the umbilical cord? Two umbilical arteries, one umbilical vein. It connects the fetus's belly button to the placenta and contains Wharton's jelly. Okay, if you observe the umbilical cord, you can see in this picture the white jelly like which surrounds the vein and arteries. Okay, that is nothing but Wharton's jelly. Okay, you can see in the picture Wharton's jelly to protect the vessels. So this jelly is formed around this to protect these two umbilical arteries and vein. And post-birth, the stump falls off in 1 to 3 weeks. Once the baby is delivered, they will cut the umbilical cord. A small stump is attached to the baby's umbilicus that will fall off within 1 to 3 weeks. Slowly it will dry off and falls off in 1 to 3 weeks. And if you observe the placenta post-delivery, this is the maternal surface and this is the fetal surface. That means maternal surface which is connected to the mother's uterus. If you after removal of placenta, if you observe, maternal surface will be like this. Cells like lumps you can observe, and it should be complete. Borders you have to check after the placenta is removed. Check for the borders. If any incomplete pieces are there, that indicates they are left over in the uterus. Fetal surface, if you observe, full of amniotic amnion layer will be there, umbilical cord will be there, and all veins. Okay, blue, red color veins, arteries distribution you can observe on the fetal surface. So once you remove, observe the placenta for complete borders and amniotic sac also. That sac also you have to observe. That indicates placenta is completely removed from the uterus. Okay, you know this you have already seen Wharton's jelly like, and it has two umbilical arteries and umbilical vein. Next question is placental variations, clinical obstetric specimen guide. Okay, At the time of development of placenta, there are some variations which takes place which will affect the placenta. If you see what are those different variations, first one is succenturiate placenta. Succenturiate placenta, that is main placental mass connect accessory fetal vessels through the membranes. Like this, through the membranes, it is connected to the fetal membranes, fetal vessels, okay, like this. Another one is circumvallate placenta. Placental edge folds inward to form a thick ring of tissue on fetal surface. Fetal surface, if you observe, it should be complete. It should be completely covered and attached to the cord. But here, placental edge folds inward. It folds inwards like this, circumvallate placenta. This is called as circumvallate placenta. Third type is battledore placenta. Battledore, umbilical cord attached right at the placental margin. Usually where the umbilical cord is attached, if you see the picture, real picture, at the center of the placenta umbilical cord is attached. But here in battledore placenta, to one corner, okay, to one edge of the placenta, it is attached, umbilical cord. That is called as battledore placenta. Next one is velamentous cord incision. Umbilical vessels travel through the fetal membrane for a distance before the placenta. Okay, before the placenta itself, they travel to a distance. Okay, velamentous cord insertion. It is not properly inserted in the middle. Okay, velamentous cord incision. Next, placenta membranacea. Extremely thin placental tissue, widely distributed over a large uterine surface. Okay, very thin placental tissue and distributed over a large uterine surface. This type of placenta is called placenta membranaca. Then placenta fenestrata. Okay, placenta fenestrata. Placenta with a central defect or missing tissue forming a discrete hole. Hole like, and this complete tissue will not be properly formed, and center you will observe a hole. Then bilobed placenta. Okay, like kidneys, you can see like renal system, two kidneys like shaped. Placenta is divided into two lobes, bilobed placenta and tripartite placenta. Placenta is divided into three parts. From the three parts, the veins and come together and umbilical cord is formed. That is tripartite placenta. Placenta accreta septum. Okay, placenta accreta septum. It is not completely covered with septum also, and umbilical cord also arising from the one corner. Okay, so these are all the placental variations: succenturiate placenta, circumvallate, battledore placenta, velamentous cord incision, placenta membranacea, placenta fenestrata, bilobed, tripartite, placenta accreta spectrum. Next question is placenta previa, very important question for final year BSc nursing students for theory and also for the practical. What is placenta previa? It is a pregnancy complication where the placenta covers the cervix. Okay, where the placenta covers cervix because there will be low lying placenta. Okay, placenta covers the cervix. You can see in the picture. It covers the cervix. Once the delivery process starts or the mother's pregnancy is progressing, as the cervical dilatation starts, the placenta gets separated from the uterine wall and it starts bleeding. Okay, so placenta, it covers the cervix causing bright red painless vaginal bleeding. Okay, red color vaginal bleeding typically after 20 weeks you can observe. Often diagnosed via ultrasound, it risks several maternal hemorrhage and fetal distress, usually requires a C-section. In this, if the placenta is like this, normal delivery is not possible. It is risky because once the delivery process starts, dilatation starts, this placenta gets separated and starts bleeding. Okay, it is very risky. So, cesarean section will be planned for placenta previa, scarring or multiple gestations. Okay, risk factors include C-section, scarring or multiple gestations. Okay, so that is about placenta previa in brief. Next one is abruptio placenta or placenta abruption. It is a serious pregnancy complication where the placenta separates from the uterus, usually in the third trimester. Okay, usually when the placenta will be separated, in the third stage of labor where delivery of placenta takes place. Once the baby is delivered, then placenta starts separating due to uterine contractions. Then the placenta will be separated. Then we will remove it for the traction. But here what happens from the in the third trimester itself, placenta starts separating from the uterine wall. Mother observes bleeding. Okay, it is one of the cause for antenatal bleeding, antepartum bleeding. It causes severe vaginal bleeding, intense abdominal or back pain, and uterine tenderness also. The tenderness creating a medical emergency that endangers both mother and the baby due to oxygen loss. Why? Because the placenta is the one which supplies oxygen nutrients to the baby. If mother starts bleeding, placenta starts separating, baby will go into lack of oxygen supply. So it is high risk and medical emergency situation. That is about abruptio placenta or placental abruption. Okay. So these are the 10 more important OBG midwifery practical Viva questions. Like, comment, share, subscribe. Thanks for watching. Please share with your friends and encourage group discussion, group studies you do so that you will remember this type of questions so that you can perform well in the Viva exam. Thank you.